welcome back to Night Nurse, my lovers of learning. Today we're going to begin to tackle fluid electrolytes and acid-base balances. It's a big thing to bite off, but we'll do it in a couple of different videos, and hopefully we can make it simple for you so you can understand it. So we'll talk about water distribution, the mechanisms, the different compartments, which forces influence water movement, and we'll talk about edema versus dehydration. We'll then, part 2, we'll get into the electrolytes, what I call the big three of sodium, potassium, and calcium. You have to fundamentally understand what they are going to do in order to understand their functions and their abnormalities. And then we'll talk about acid-base balance and actually get into blood gas interpretation. First, though, we're going to talk about water. So the physiology of water. What does water do? Water maintains blood pressure. It is the hydrostatic pressure that creates blood pressure and allows for tissue perfusion. It transports nutrients into the cells, and it transports waste out of the cells in a tidal effect that we'll talk about. It transports oxygen into tissues, so whenever you hear dehydration, you have to worry about cellular hypoxia and possibly anaerobic metabolism. So body water composition is considered total body water percentage, and adults are about 60% water. The women and obese and the elderly are about 50% total body water, so they're always a little bit dehydrated, so you have to remember that puts them at a little bit more risk. And then infants are actually 70% total body water, but they don't know how to concentrate it, so they can have trouble too. So the result is that women, obese, and elderly are at greater risk for dehydration during any type of illness. So when you think of people being admitted, often it's the elderly, right? And the very young because of their high total body water percentage because they don't know how to regulate it. So most of the total body water is inside of our cells. And it seems very confusing, but I want you to just think of it simply. There are two major fluid compartments we're going to talk about. One is the vasculature or the pipes. Those are the arteries and the veins. And then the other one is the interstitial fluid and cells that surround the pipes, that the pipes actually feed their nutrients and fluid to. So, major water components and their fluid shifts, remembering that most of the water is inside the cells, that's the intracellular fluid. But when we talk about extracellular compartment, you have all this other area. What is it made of? It's made of the vascular pipes, the intravascular compartment. And this is where you draw labs. So whenever you see a lab value, you need to orient yourself that is the vascular level, that's the vascular sodium or potassium measurement. So we have the pipes. Then we have the interstitial fluid, which is the fluid around the cells that bathe the cells. So, simply put, when we talk about fluid shifts between the vascular compartment, between the pipes, and the interstitial and cellular compartment. And they do it in a tidal fashion, high tide, low tide. So what that looks like is in the arterial circulation, you have very high hydrostatic pressure that pushes fluid out of the high pressurized arterial pipes and pushes it in past the capillary membrane and into the interstitial fluid to bathe the cells. Conversely, in the venous circulation, hydrostatic pressure is very low because the veins are dilated, they're kind of chill. All right, so they don't have nearly as much hydrostatic pressure, and now that allows this osmotic sucking pressure, like a sponge that is inside the vascular pipes, to suck the fluid back into the vascular pipes in a tidal fashion. So what's making this happen, right? I mean, it's not magic. So what's going on? Well, there are two major forces dictating this tidal fluid movement, and then there's one that I give an asterisk because it's important. The first one is hydrostatic pressure, which is the pushing pressure that shifts fluid from the vascular compartment pipes into the interstitial, intercellular compartments to bathe the cells. This is high tide, it's a piston pressure. And the major controllers of this is blood pressure. So the sodium-potassium pump increases vascular volume by bringing sodium into the vascular compartment, which also brings water in. And we'll talk about that. High blood pressure or vasculature vasoconstriction also plays a role in hydrostatic pressure. Now the other one is osmotic sucking pressure. Osmotic sucking pressure is the pulling or sucking pressure to get the fluid from the interstitial and cellular compartment back into the vascular pipes. So what controls that? It's controlled by osmosis, water moving from high concentration to low concentration. And this is namely controlled by sodium concentrations and the blood protein albumin within the vascular compartment. And this is going to pull fluid back into that vascular compartment. The asterisk is capillary permeability because it sometimes plays a role in certain illnesses. And capillary permeability is how porous is the capillary membrane to allow fluid to get through. So when we talk about histamine increasing the capillary permeability in inflammation, this is what we're talking about. So we have to keep that in mind. So we have this hydrostatic pushing pressure, this piston pressure, like the pushing pressure through a syringe. Then we have the osmotic sucking pressure trying to pull fluid back into the vascular pipes, working against the hydrostatic pressure. So who wins? Well, let's explain osmotic sucking pressure first. It tends to be a little bit harder for people to understand because it's a sucking pressure. Now remember, osmosis is the free flow of water from high concentration of water to low concentration of water. Sounds really confusing, doesn't it? Sounds like something a chemist would come up with. So let's just put it simply. Water moves towards higher salt concentration, towards higher osmolarity. So the way I put that is Ladies Night at Club Oasis, right? Dance clubs offer free admission and appetizers to women to their club. It's costing them money. They lost the admission fee and they lost the appetizer. Why in the world would they do that? They do that because they're spending energy to bring in the ladies, because free ladies night means that many overpaying men will probably come in effortlessly. Don't have to give them a coupon or anything. This is osmosis. Well, our body uses this physiologically. It moves sodium to control the movement of water. Wherever sodium goes, water will follow. Wherever sodium isn't, water will leave, just like how many ladies are in the club. So the hypothalamus and pituitary will use the endocrine system in the same manner to use sodium and other factors to influence osmosis and put water where it needs to be. Sometimes it goes bad. What is this hormonal control of fluid and electrolytes? Well, first, antidiuretic hormone, which is our thirst mechanism, comes from the brain. So when we have high sodium in the vascular compartment, remember you're drawing labs from the vascular pipes. So when I say hypernatremia, that's where I drew the labs, so the high sodium is in the vascular compartment. So when I have hypernatremia, high sodium, this causes the pituitary to secrete antidiuretic hormone. Antidiuretic hormone then goes to the kidneys and has the kidneys reabsorb more pure water back into the vascular pipes. This more water in the vascular compartment dilutes the vascular sodium and adds volume. There's also a vasoconstriction component to increase blood pressure. So the result of that is more blood volume and lower blood sodium concentration. Now the renin-angiotensin-aldosterone system, it is regulated by the kidney blood flow called the glomerular filtration rate. And whenever the kidney has low GFR, low glomerular filtration rate, then that will cause the kidney to release renin. Renin secretion activates another hormone called angiotensin II. It takes a couple steps to get there, but with angiotensin II, it stimulates the adrenal gland to release aldosterone. What does aldosterone do? It goes back to the kidney and tells the kidney, hey, reabsorb more sodium back into the vasculature. And guess what? When the kidney brings sodium in, guess who follows? Water follows. So you get increased sodium and water reabsorption back into the blood. That's Ladies Night at Club Oasis. Wherever sodium goes, water's going to follow. If sodium's low, water is going to leave that compartment. It also leads to higher blood pressure and better tissue perfusion. Now, angiotensin has a twofer because angiotensin stimulates arterial vasoconstriction, makes the pipe squeeze tighter, and that increases blood pressure to increase blood flow. So the result is higher blood sodium and more blood volume and a higher blood pressure. Finally, we have natriuretic hormone. It's usually called BNP, and it is stimulated by high cardiac pressure, so high blood pressure. What happens is high blood pressure stimulates the release of natriuretic peptide, and the natriuretic peptide stimulates renal excretion of sodium. And so guess what goes with the sodium? Water. So now we have excretion of sodium into the urine, and water follows. This causes a loss of sodium in water, and it decreases blood volume and lowers the patient's blood pressure. The result? Water loss, lower blood pressure. One more little note to remember when we get into the electrolytes, that this is all controlled by the sodium-potassium pump that uses ATP. And whenever the sodium-potassium pump moves sodium one way, it moves potassium the other way. It's like a swinging door on the front of a condominium. Okay? It is a revolving door. Sodium goes one way, potassium goes the other. So whenever the kidneys actively move sodium in one direction, it will move potassium in the opposite direction. So now let's look at the tidal movements of fluids based on hydrostatic versus osmotic sucking pressure. So the hydrostatic pressure, push force, was the shift that shifts fluid, the pressure that shifts fluid from the vascular compartment into the interstitial and intercellular compartment. Major players, blood volume, sodium keeps water in that vascular compartment and maintains blood pressure. Also vasoconstriction, which increases blood pressure within the vessel. Arterial pressure usually sees high hydrostatic pressure, which is higher than the osmotic pressure, and this forces fluid out of the vascular pipes into the interstitial fluids. We call this high tide. We also can have lymphatic obstruction. Think of lymphatic obstruction or the removal of lymph nodes as a clogged gutter or a clogged drain. We get reduced interstitial drainage, and this is going to cause more resistance to flow and increase hydrostatic pressure. So let's take a look. You have your blood pipes, vasculature, you have a capillary membrane, and then you have your interstitial fluid and your cell. In the arterial circuit, you have high hydrostatic pressure pushing fluid from the vascular pipes into the interstitial intercellular fluid to bathe the cells and give them what they need. Factors that keep high hydrostatic pressure are blood pressure, which is very high in the arterial circuit, vascular volume, and vasoconstriction are what control blood pressure. Then also lymphatic obstruction can be a problem. Now, even in the arterial circuit, you have osmotic sucking pressure, you'll see, because it's based on sodium and albumin. It's in the arterial vascular pipes, but it's just not enough to pull the fluid in the direction of the pipes. This high hydrostatic pressure pushes it out into the cells to bathe the cells. Now, you can get too much high hydrostatic pressure. If you get too much hydrostatic pressure, that's going to lead to fluid just hanging out in the interstitial fluid and cellular compartments, and this will cause edema. Now, when we look at the osmotic pulling pressure, that's the pressure that pulls fluid from the interstitial intercellular back into the intravascular compartment of the pipes. Major players were osmotic pressure to pull that water back into the vasculature. That's Ladies Night at Club Oasis. Also, the players were blood sodium and blood albumin, which act as sponges to suck the water and pull the water back into the vascular pipes. Also, keep in mind that venous pressure in the veins, osmotic pressure is the same, but hydrostatic pressure drops because the veins are chill. They're all vasodilated and they're not nearly as uptight as the arteries. So that lowers venous pressures to the point where osmotic pressure is higher than hydrostatic pressure. So the net force pulls fluid from the interstitial intercellular compartment back into the vascular pipes. So this is low tide. Tide goes back out. What's it look like? So again, you've got your pipes, your vasculature, you have your cellular membrane, you have your interstitial fluid and your cells. You do have some hydrostatic pressure because the veins do have some pressure. It's just not very much. Now you have an osmotic sucking pressure that is higher than the hydrostatic pressure. So it wins the tug of war. Factors of the osmotic sucking pressure are vascular sodium and albumin. Those are the big ones in the vascular pipes. So it pulls fluid back into the pipes and allows the wastes and old fluids that were around the cells to get back into the bloodstream to be eliminated. So it's a perfect system when it's working well. Now, things can go wrong. If you have low osmotic sucking pressure, maybe you have low vascular sodium, you have low albumin, you don't have the sucking pressure. So what happens? Fluid just hangs out in the interstitial fluid, doesn't get sucked back in, and we see edema. Okay? Also, not very much blood pressure. Now, the opposite of that is having high vascular osmotic sucking pressure, which you can have. Let's say you have very high vascular sodium levels. Well, that water is just going to be sucked into that vascular compartment like there's no tomorrow. And it's actually going to dehydrate the cells, called crenation. They crinkle up like a raisin, and they don't work as well. And there's a whole bunch of fluid in the vascular pipes now, and that leads to vascular overload. So let's look at edema and dehydration. Edema is when the intravascular fluid shifts into the interstitial fluid. And edema is excessive amount of fluid in this interstitial compartment. So you see swelling, you see enlargement of intestinal and cellular tissues. What in the world causes this? Well, you kind of know. Increased hydrostatic pressure from hypertension, hypervolemia, or obstruction of the lymphatic system is going to cause a backup and cause an increase in fluid hanging out in the interstitial fluid, and that is edema. You can also have low vascular osmotic sucking pressure. There's just no pull from the vascular pipes, from low albumin, low red blood cells, or low sodium in the vascular compartment, so that's going to let fluid hang out in the interstitial fluid and cause edema. You can also have increased capillary permeability. A certain little special illnesses like systemic inflammation, which happens with anaphylaxis, or sepsis, those increase capillary permeability and cause the fluid to leave the vascular compartment and go into the interstitial fluid, which causes a loss in hydrostatic pressure and a loss in tissue perfusion. It can happen very quickly, like an anaphylaxis, or it can happen kind of like a slow burn with sepsis. Either way, it's deadly. Now, the manifestations of edema can be generalized edema, where it's all over. It's often dependent edema, so it's found in the feet after someone's been walking. It's found in the buttocks or sacrum when they're lying in bed a lot. It's basically falling towards gravity. Pitting versus non-pitting. Pitting edema, if you push your finger down on it and let go, it'll leave a pit mark. So that's pitting edema. Manifestations of all edema is weight gain, water retention. This is the reason that we have daily weights on some patients, and clothes will be tight, and they may have decreased joint movement because the joint area is swollen. Dehydration is the opposite. It's insufficient vascular fluid. Insufficient bodily fluids of dehydration can occur either from excessive loss or inadequate fluid intake, or both can be happening. So mild dehydration is 2% total body loss, moderate is 5%, and severe is 8%. Now recall that dehydration is more serious in the elderly and obese because they have lower percent body water, also in infants because even though they have high body water, they don't know how to conserve it. Causes of dehydration can be vomiting, diarrhea, excessive sweating. It can be diabetes, where they pee sugar out. Glucosuria is what it's called, and that causes the loss of water, polyuria. Insufficient water intake. It can occur through insensible loss, where someone has a fever or they're breathing very quickly and they're actually blowing off a lot of water vapor, and that's causing dehydration. Or through third spacing, non-functional collection of fluid, where this patient actually weighs the same. They haven't lost any fluid out of their body, but now it's in that third space. It's neither in the vascular compartment maintaining tissue perfusion, or in the cells taking care of the cells. It's in that third space. And so they will show up like they're dehydrated. What does a dehydrated patient look like? Well, we have to look at vascular and cellular sides. So you have dry mucous membranes, decreased skin turgor. That's pretty bad dehydration. Actually, the first sign of dehydration is often tachycardia and hypotension, and then a weak, thready pulse and fatigue if it gets worse. Now, if someone's dehydrated, remember I said dehydration equals hypoxia. So if someone's dehydrated and they're not getting good tissue perfusion and they're having cellular ischemia, the cells will undergo anaerobic metabolism and start making lactic acid. That's metabolic acidosis. They'll be very thirsty. They'll be secreting ADH. They'll activate their sympathetic nervous system, release of the hormones called the catecholamines. They're epinephrine and norepinephrine. Those are your fight or flights. Makes the heart rate really fast, causes everything to vasoconstrict. The whole purpose of that is to try to get that blood pressure up. But they'll have very pale, cool skin. Labs will usually show hypernatremia because they've lost a lot of their vascular fluid, which super concentrates the sodium. So the sodium level is high. This causes cellular crenation, and the cells lose their function, and this can cause mental confusion and decreased level of consciousness. Now, what do? We can replace it with IV fluids, right? And IV fluids are typically thought of in their form of osmotic pressure or salt-sucking pressure. That's what tonicity is. They're either isotonic, hypotonic, or hypertonic. Now, isotonic fluids have the same osmotic pressure as your normal vascular compartment. So there's no fluid shift here. The tonicity is about 300 on the bag, and so the purpose of this is to treat and restore blood pressure and perfusion without any massive fluid shifts between the two compartments. Examples of this are normal saline and Ringer's lactate. Now, hypotonic fluids have lower osmotic pressure. So this means you are diluting sodium when you give them a hypotonic solution in their IV. So the fluid shifts away from the vasculature because you're lowering sodium. So, less sodium means water is going to go somewhere else. Fluid shifts away from the vasculature and it gets pushed into the cells. This is good for treating cellular dehydration after someone's been dehydrated a long time. Try to get some fluid right into those cells right away. Examples of this are half normal saline. You have to be very careful giving these fluids because you'll just keep on pushing fluid into those cells and you can cause edema. Now, hypertonic fluids have higher osmotic pressure than the vascular compartment is supposed to be. So this means it has a lot of salt-sucking pressure, so the fluids are going to shift toward the vasculature away from the cells. So this is great when you have edema and you're trying to fix edema. Examples of this are 3% sodium chloride, mannitol, which is a large sugar that can't be absorbed, stays in the vasculature, and is really just there to give osmotic sucking pressure. And also albumin, which is a large protein that stays in the vascular compartment. Great for treating edema, specifically cerebral edema, to pull that fluid back in the vascular compartment. Now, you may also see crystalloids and colloids. Don't let this freak you out, all right? This is just a different way of talking about IV solutions. Crystalloids are any IV fluid that contains dissolved salts like sodium chloride, D5 half normal saline. It's just a crystalloid. It's a dissolved crystal salt within a solution. Whereas colloids are large molecules, either a protein like albumin or a big sugar that we can't break down like mannitol. And these large molecules stay in the vascular compartment and just serve to give a tremendous amount of osmotic sucking pressure to treat edema. So don't let that scare you if you see that. Okay? So that concludes part 1. Next, we'll get into electrolytes. Thanks for watching. Hope you enjoyed it. If you did, be sure to subscribe to the Night Nurse Learning channel by clicking below here. You can also find more information at nightnurse.com. And thank you for listening.